Thank you for that introduction, Kevin, and thank you for inviting me to be a part of the program this evening. I think we've got a very nice sized group for discussion. I'm looking forward to the interaction that we're going to be having after the formal presentation, and I hope you'll take some notes and think about some questions to prompt our discussion. As Kevin mentioned, my presentation this evening is about how a number of the policy drivers in the new healthcare environment actually fit together in order to promote what we call the value agenda. And I also want to talk a bit about strategies for success in accountable care. I don't believe are primarily providers, but we all have a role as stakeholders in promoting the success of accountable care, and you can see some of the considerations that when I go out to talk with providers about how to be successful under the various policy drivers of the value agenda, the kinds of conversations we're having there, and it should be relevant to our discussion. So the first starting place is defining what we mean by the value agenda. So value is composed of components of both cost and quality. And all of us who work in healthcare or are stakeholders in healthcare know the grim picture that we have costs out of control relative to the other OECD countries you see listed here on this slide. And the unfortunate part is that our quality does not keep pace with the cost. And so, by definition, if value is a function of the quality per unit cost, I was completing the other aspect of the cost-quality equation by pointing out that U.S. healthcare is on many of the important quality parameters at the bottom of the list for these. And there have been many efforts in the private and the public sector, the most notable 5 years, of course, being the Affordable Care Act. The Affordable Care Act has a number of provisions in it that are meant to enhance the value of care. First of all, and the provisions that get the most attention are the access provisions, the health insurance exchanges, Medicaid expansions, and commercial insurance mandates. But there are others that are important to the quality landscape as well. For example, building the evidence base through comparative effectiveness research. What are the more effective interventions that we can take to improve quality and value and decrease costs? Population health, upstream prevention of disease in a more cost-effective manner. The quality provisions, which I'm going to be focusing on during most of the rest of my presentation. And then the delivery and payment reforms from the Center for Medicare and Medicaid Services, primarily from a policy perspective. So when we talk about value, it is about the relationship between cost and quality, and you've probably seen graphics like this before, where we know where we are, high cost, relatively low quality, and where we need to move to, which would be on what's called the efficient frontier, that curve that reflects where the quality outcomes are the best that they can be for a given level of investment of cost. And so basically we need to move northwest on this particular graphic from a higher cost, lower quality position to a lower cost, higher quality position. And this is just a summary of how all the pieces that I'm going to be talking about this evening actually fit together. So across the center of the slide, left to right, you see priorities on the left-hand side. We've got to start by knowing what we want to accomplish, and that's the National Quality Strategy, one of the quality provisions in the Affordable Care Act. And once we know what we want to accomplish, we need to be able to measure where we stand relative to those goals, where there are opportunities for improvement, and where we're making progress over time. And that's the value of measurement. And then ultimately, of course, the goal is to improve through different delivery models that are supported by measurement and by a data infrastructure that allows for the efficient and effective exchange of information. So that's the underlying infrastructure support you see there. And then we also have various programmatic approaches to enhancing policy through the use of measurement information across the top there. Accreditation certification, like, for example, physician board certification or facility joint commission accreditation. The use of information for HIT incentives, like meaningful use or value-based payment, and ultimately public reporting for full transparency. And I know from a safety perspective that transparency is one of the dearly held values of this group. So this is sort of the roadmap, if you will, to my presentation and how these policy drivers fit together. So let's start with measurement. Or actually, let's start with priority setting, right? Because I said you start with priorities to define where you want to go and what you want to accomplish. And I expect that you're all aware of the National Quality Strategy and the three-part aim that consists of not only better care that we've been focused on in healthcare quality over time, but also now more attention to health, helping people in healthy communities, as well as the cost component, affordable care. And you can see the priorities under the National Quality Strategy that tie back to the three-part aim, including health and well-being and prevention for healthy people, healthy communities, treatment for better care, person-family-centered care, effective care and coordination for better care, safety, and then ultimately affordability is a priority in and of itself. So now let's shift to quality measurement. How can measurement help us to meet the objectives that we have under the National Quality Strategy? So starting at the top of the cycle of measurement as presented here, the first step is to prioritize the gaps that we have in the provision of quality care. And those, again, are defined in the National Quality Strategy. We may have measures for some of the elements or the priorities of the National Quality Strategy, but we may also have measure gaps. So we need to fill measure gaps that we have, and then once we have measures, to standardize and harmonize those measures so that we're all focusing on consistent, important things across the quality landscape. Select the right measures for the various purposes that we have in using measures to promote better care, and making sure that they're aligned across purposes. And I'm going to talk about the importance of alignment as part of the subsequent slides. And then once measures are implemented, we need to be able to assess the impact. And the impact that we've had on moving the needle feeds back into our priorities and our focus areas, whether we're focused on the right things. And just like in the value agenda slide, that electronic data platform underlying measurement is very important because you can't calculate measures without data sources. So when I'm talking about measurement, I like to be sure that the audience understands that that it's not realistic to believe that measurement is going to resolve all of the quality problems in our system, because not everything that counts can be counted, and not everything that can be counted counts. This is a quote, as I've learned, not from Einstein, but from a gentleman named Cameron, who was actually a sociologist. But apparently Einstein did write this quote on his blackboard at one point, which is why I included the picture. But even though there are limitations to measurement, we also recognize that you can't improve what you don't measure, a basic tenet of management that comes from Deming and others in the total quality management world. So there are also differing perspectives on measurement. The clinicians and providers want to be sure that the effort that's being put into measurement is actually meaningful and actionable. Are we measuring things that are actually going to make a difference to outcomes and give guidance to the providers on what to do in order to improve those outcomes? And they're also very interested in fairness and burden. So the appropriate adjustment of measures for fair comparisons, especially if the information is going to be used for payment and for public reporting, impacting wallets and reputations, and that we're not taking too much time and effort away from good clinical care or improvement efforts just to do the data collection. But consumers and purchasers have a slightly different point of view, or perhaps a very different point of view. They hold transparency as a primary objective to make sure that providers are accountable for the care that they're providing, whether it's the safety or the cost or the effectiveness of the care. And sometimes the things that consumers and purchasers find meaningful in quality measurement are different than what clinicians and providers find meaningful. So consumers and purchasers want outcomes. They want rolled up information in composites. And sometimes the providers say, yeah, but that's great, and we like to see that outcomes are improving, but if they're not improving, we need other kinds of measures, like process measures, that tell us where we should focus our activity. And in the end, the consumers and purchasers are very adamant about not waiting until measures are perfect in adjustment or in terms of perfect fairness in order to make the best use of the information that we have. So the National Quality Forum, which takes account of all of these perspectives, has settled on 5 endorsement evaluation criteria. And the reason that I include these in the presentation is to give you a sense of what makes a good measure. The good measure needs to be important, meaning that there's an improvement opportunity and it's a high priority area. Needs to be scientifically acceptable, meaning that it needs to be reliable over time in measurement and also valid for what we're trying to measure and improve. Needs to be useful, that action can actually be taken to improve on what's being measured. Needs to be feasible, that is that there's a data source that can be collected without undue burden. And it shouldn't be duplicative or misaligned, and that's this idea of competing and related measures. So in terms of the scientific acceptability, a measure could be reliable and not valid. That's not good because it's wrong. It's not measuring the thing that we want to measure. It could be neither reliable nor valid. We know that's not good. But what we'd like to see is that measures that be both reliable and valid. That means consistent over time and correctly measuring what we're after. And that's a lot of what goes into the testing and endorsement of measures. Now this slide contains a synthesis of a number of measurement issues that are either challenges to valid and reliable measurement or that represent future opportunities for us to improve measurement. So focusing on meaningful outcomes as opposed to disease-specific process measures and cross-cutting topics like care coordination is a trend for the future to get at the things that are really important to patients. Focusing on cost of care to get at that grim picture of value that I presented at the outset. Focusing on patient-reported information, again, things that are really important to patients, like their functional status. If you had the hip replacement surgery, are you able to walk or play tennis or whatever your goal was after that surgery? The symptom burden, particularly pain, is important as a symptom. And the patient's experience of care. Are they able to understand what the providers are trying to communicate? Are they able to get active in their care and be a true partner? Those are really important now and into the future of measurement. I'm mentioning composites as a way to roll up information in meaningful ways for consumers. E-measures, which make use of that electronic data infrastructure to decrease the burden of reporting and enable measurement across time and across settings in ways that we haven't been able to measure before. A focus on population health. This again reflects the triple aim, the movement toward just better care in a single setting. So looking more broadly at the whole population that a provider might be accountable for, and how health care relates to public health is another aspect of population health. Well, chronic conditions is becoming more and more important as we look at the aging Medicare population and the fact that many patients have 5, 6 more comorbid conditions at any point in time, and we need to figure out how to measure the effectiveness of care for those patients. And then things that are important to the providers. Alignment of measures across programs so that they make more sense and so that the burden of reporting is less, which means getting to core measure sets and things that the providers can actually focus in and improve on. So as you can see, we've got a lot of issues ahead of us in improving measurement and having it be maximally effective for promoting the kind of system that we want to have under accountable care. So one of the issues that I've mentioned a couple of times already has to do with measure alignment and the relationship between alignment and burden. So this slide comes from a group in Massachusetts called the Quality Alignment Initiative, which was a part of state government at one point in time. I can't find them on the internet anymore, so I don't know whether they've been absorbed into a bigger agency or whether they've been disbanded. But I don't believe their work is done, so I hope they haven't disbanded. You can see the plethora of measures that have been proliferating in Massachusetts, whether it's requirements for federal programs, 190 measures you see there, from commercial insurers, 197 measures, from state programs, 335 measures. This creates confusion on the part of those who are trying to use measurement information, and it creates this burden of data collection. You can see there's some intersection and overlap, and a lot of folks are looking at where there is intersection, because those could potentially be opportunities for core measures across many different kinds of providers. So a lot of groups are working on alignment at the moment, and if you have questions about that, we can make that a part of our discussion. Basically, what we need to think about is how to get to that ideal point where we've maximized the information that we're getting about health care and the services that are being provided, as well as the health of the community and cost, and decrease the confusion. So where we have too little information, on the left-hand side of the graphic, we don't have enough information and we're confused. If we have too much, we also get into that same situation. And we have the pendulum swinging now from left to right, and we need to find that sweet spot. I include this slide as part of the measures part of the presentation because I do want to show that we are having an impact through quality improvement and measured progress over time. The green line in this slide is the rate of adherence to the optimal diabetes rate. It's a measure that's been developed and been endorsed by the stewards at Health Partners in Minnesota. I think we have at least one Minnesota person on the call. And as the optimal diabetes rate has improved within the Health Partner system, we see that new cases of retinopathy and amputation and acute myocardial infarction have decreased. So we know that better adherence to the kinds of interventions that are part of that optimal diabetes rate have actually resulted in the better outcomes that we see on this slide. But to bring us back around to the value theme, basically what we need is good measures of health and healthcare outcomes that are relevant to patients, like functional status, and follow them over time, paired with good measures of total cost over the entire episode of care for that patient. And that'll give us a picture of value, as you see there. And that's the power of measurement. But measurement does not stand alone, because as I said earlier, we really have to have those data sources that can be collected in efficient and reliable ways in order to calculate the measures. We've got to capture the right data to get our performance measure calculated, and then we need to have that information available in as close to real time as possible to support better care, decision-making by clinicians, decision-making by patients. And then we can also use that information for other purposes beyond the care and the workflow, like public reporting or payment, or for quality improvement that relies on retrospective information. So we have a lot of data sources out there. The current thrust is to try to get them to talk to one another and be able to be used in concert rather than in individual silos. So we have pharmacy and lab information as clinical data. We've got claims information. That's sort of our traditional information for quality. We've got registries that are being used more and more. The ideal being having all this information be collected through electronic health records, because then it can be just a part of the care flow and be generated from the care flow, or can inform decisions at the point of care. And then we have special systems that hospitals and other facilities have. So we've got a lot of work to do to bring these data sources together so that the traditional claims base can be enhanced by clinical information and electronic health record information, the robust big data collection in registries, and also supplemented, importantly, by patient-reported information. Because as we have social media and other kinds of ways to collect that information, that's going to be very valuable for us for the future, for understanding what's going on with the patient from their perspective. So the ideal infrastructure would have electronic health record information that's interoperable, that would provide us with clinical decision support for physicians and patients and other clinicians at the point of care, would provide analytics and communications tools in order to bring all of these sources together into measurement and improvement systems. So this is just a graphical representation of what I said about data sources. The idea is that they ought to all be working together. The clinical guidelines informed by the evidence need to be used to generate quality measures, which together with other information sources should provide real-time clinical decision support at the point of care. And that then will lead to the sweet spot of information availability in order to support better care. This is going to require interoperability, the ability to track patients across different settings and make sure that we're not providing duplicative or unnecessary care, and that we're not missing things that have been unearthed in the previous setting of care. So once we have this information, how can we use it effectively? Well, we could use it for accountability purposes. I'm going to be talking about performance-based payment primarily, also public reporting. We could use it for transparency. Clearly that's related to public reporting and very important to the safety work that you all are interested in. Some of those purposes that you see there are provide for less accountability and less transparency, like internal uses, quality improvement with benchmarking, for example, more accountability through certification, accreditation, more accountability through payment incentives, ultimate transparency through public reporting, and that supports consumer and purchaser decisions about seeking care, with the ultimate goal, of course, of all these uses of performance measurement information being about improved health and health care under the triple aim. But we ought to add cost to that as well, because ultimately it's about value. Now this slide has a lot on it, but it is a way to demonstrate how a lot of those purposes relate to one another. So if you take the purposes of integrated delivery, which is across the bottom of this slide, all the way from independent physician practices on the left-hand side of the X or the horizontal axis over to fully integrated delivery systems on the right-hand side of the horizontal axis, and compare that to a more integrated approaches to payment on the y-axis or the vertical axis, where we have fee-for-service transitioning into bundled and ultimately the global types of payment in a more integrated fashion. When you put those trends together, and we'll be talking more about delivery system integration toward the end of this slideshow, we'll be talking more about payment integration in the next few slides. When you put those trends toward integration together, it really both requires and enables different kinds of measurement. So when you have less integrated approaches, like independent practices and fee-for-service, you're primarily measuring processes for patients in a specific setting at a specific point in time. But as you get a more integrated approach, you can actually have more sophisticated kinds of coordination measures across different types of settings, and ultimately outcome measures for populations. It's not only the different measures that are enabled, but there's different data sources that you get as you become more integrated in delivery and payment. And so we're going to touch on some of those concepts here. So one of the purposes I mentioned of performance measurement information is for performance-based payment. And that's the movement from volume to value, not only in Medicare, but in many private sector payment approaches as well. And we see some of those programs listed here for physicians, for PQRS, for example, value-based payment modifier, for hospitals, the quality reporting programs, inpatient, outpatient, and the value-based purchasing program for hospitals, to compare websites for transparency, the meaningful use incentives to build the infrastructure, and system-level approaches like Medicare shared savings. And in these programs, measurement serves multiple roles. Obviously paying differentially, which is an accountability mechanism to promote the kind of care that we want to see and the avoidance of inappropriate care, but also to protect against unintended consequences of payment incentives. We have to be able to monitor the quality of care over time to see if there are potential unintended effects that are undesirable in the application of incentives, and then to ultimately support performance improvement. This slide is just meant to show the many different programs now in Medicare that are using performance measures. There are over 20, and not all of them are listed here. The ones relevant primarily to clinicians, hospitals, and post-acute long-term care programs. But then there are also, for example, the Medicare Part C, Medicare Advantage, and Medicare Part D prescription drug plan performance measurement programs, the star ratings. There are also then the programs for Medicaid and the Children's Health Insurance Program, the core measure sets for those. So there are a lot of different federal programs using measurement now, and sometimes folks don't realize how many of the programs there are out there. But the policy drivers aren't complete without applying them to the front line to change care. And the systematic approach that's emerging is integrated care delivery. I took 4 or 5 different definitions of integrated care delivery and did my synthesis here. Basically defines integrated care delivery as a coherent approach to organizing, delivering, and funding services for creating connectivity, alignment, and collaboration across those services, not only among different types of providers, but within those provider types, across the functions that they perform and their settings over time, with rewards that support higher value. I'm going to talk about some of those aspects in the remaining slides that I have. And of course, the goal is improving access, quality, and health outcomes at the population level, as well as at the individual level. Enhancing the patient and physician experience. You could substitute the word clinician there, broader than just physicians, but it's about having the experience of care being more meaningful for both those who are being cared for and the caregivers. And then lowering cost of care through more efficient delivery. Some of the implications are that patient-centered care is better care. We're seeing this more and more in the literature, that when patients and families are engaged as partners in their complex chronic illnesses, we can see better health and health care outcomes. That cost savings result from the efficiency, less waste, economies of scale in these larger, more integrated systems. We're not yet seeing the savings, the full savings from these upfront investments, but we believe it's there, and it's a way to take waste out of the system. Higher satisfaction for patients and physicians, I mentioned, and rewarding doing the right things well, aligning payment incentives with the kind of care that we want to see. Lots of layers to integration that begins within a practice. So making sure that there's coordination among that care team. And then with other providers, between primary care and specialist physicians, for example, between clinicians and facilities. Then more broadly with the community. Sometimes forget this piece, but people spend most of their time not as patients, but as people living in the community. We need to be integrating the medical services with the social services. And then the payers have a role too. They have a lot of the information, the data, and they can use incentives to support better care. One of the models that's emerging is the patient-centered medical home, and that's now even being expanded to the concept of a patient-centered medical neighborhood, which includes not only the primary care physicians that we usually think about when we think of patient-centered medical home, but also the specialists. And some of the functions of the medical home are demonstrated here. Enhanced access for patients, where they have a personal provider who can provide them with continuity and care coordination, where they're in a safe environment where quality is being measured, and there's focus on the whole person and not just the illness. And there's an infrastructure that supports that in terms of capability and accountability. So the NCQA has a recognition program that looks at these functions of access and use of data for population management and some of these other important aspects that I hit on in the last slide. The patient-centered medical home is only one of the delivery models that are coming online. Another one is accountable care organizations, where we're seeing vertical integration, meaning that physician practices are affiliating with hospitals or affiliating with post-acute long-term care facilities that are all together as providers affiliating with health plans in order to come up with these various different systems approaches to providing care. And those integrated systems then are accepting risk through fee-for-service with risk arrangements like shared savings or global payment behind them. And then when I talk to providers about this new world and their role in it, they like to hear about various strategies for success. So the first and I believe the most important is to focus on truly patient-centered care. And that means establishing a new culture, a culture that has open access, that allows the patient to drive when they're going to receive care, not the provider. Allows the patient to be the center of communication and have that communication customized to them in ways that they can understand it. To have the patient be the driver of the care plan that's developed in partnership with them and takes account of their preferences and involves them in the decisions that are made there. And that in addition uses everyone across the team to support that patient-centered care culture. Everyone working at the top of their license and contributing to the patient's experience and their health. Optimizing the workflow then to match the culture through various quality improvement initiatives. So once you've got that patient-centered culture, it's also the responsibility of the providers to manage the risks and costs to a greater extent than ever. Through the various accountable care approaches, payers are actually pushing some of these responsibilities for managing risks and costs onto the providers. But the providers can do it in a way that takes account of not only the cost, but also the quality of care and balance those two aspects. It requires them understanding where their highest risk patients are and being able to coordinate and communicate in order to focus in on meeting the needs of those patients and prevent those unnecessary visits to the emergency department or those unnecessary readmissions to the hospital. And it requires being aware of and adhering to clinical guidelines. A lot of, we would just expect that, of course, from professionals, but sometimes it's not happening. The third strategy then is to use measurement to manage quality, measuring what's important to that practice as well as what's important for accountability purposes in order to improve the population health outcomes and the health for individuals and improve the systems of care through various projects and tools that are made available, education for the whole care team. Leveraging health information technology. So using predictive modeling, clinical decision support to focus in on what needs to happen to improve the quality of care. And that also includes attention to retrospective information about quality and cost and utilization. And last, but perhaps most importantly, we really need champions. And it isn't just physician leadership. It's leaders really from all stakeholder groups across the whole spectrum of care. It's leaders like the people who are on this call to engage in planning and managing change. And then to be a part of systems that really reward that kind of engagement. Where we see better value of care being provided, there needs to be the appropriate rewards in place for what we want to see. So that's the end of my prepared remarks, and I'm going to turn it back over to Kevin to open it up for discussion and be our moderator.